Good afternoon, everybody, and welcome to Grand Rounds today. Today it's my pleasure to introduce Jill Bode. Jill received her Doctor of Pharmacy degree from Drake University. She currently is an adjunct assistant professor in the College of Pharmacy at the University of Iowa. Here at MGMC, she sits on the Medication Safety Committee, the Drug Diversion Committee, the PNT Committee, and the CME Committee. Most importantly, she is also co-director of the Antimicrobial Stewardship program here at MGMC, and she very kindly has accepted our invitation today to give us a review of antimicrobial stewardship. And please join me in welcoming Jill Bode.
Thank you. I think it's been a few years since we've had a Mary Greeley update on antimicrobial stewardship. It was kind of hard to narrow the focus of this. All the infections are free game to be included in this topic, but I decided to start with, let's see if I can use this. I don't have any disclosures. These key objectives highlight how we apply the CDC's core elements of antimicrobial stewardship to support patient care. There's been a couple guideline updates recently, so summarize some key changes in empiric antibiotic selections and duration for community-acquired pneumonia based on the 2025 ATS guidelines. Review the 2025 IDSA guidelines on UTIs, focusing on new classifications, again, antibiotic selection and treatment duration. All big deals for antimicrobial stewardship. And then finally, explain strategies for evaluating and delabeling beta-lactam allergies to optimize antibiotic use. So kind of a variety of topics to give you some little pearls to take with you. You've got to show the CDC's core elements. It's the backbone of our program here at Mary Greeley. It includes hospital leadership, accountability, pharmacy. It's that we take action, we track, and we report and we educate. So this is really for any committee or group that wants to be effective. Having all of these core elements is a good framework. And we are required to do this for CMS and our accrediting bodies as well. Antimicrobial stewardship, for those who need a reminder, is a rational, systematic approach of the use of antimicrobial agents to achieve optimal outcomes. I'll try not to keep reading off the slides, but it's using the right agent at the correct dose for the right time, and we want to minimize adverse events and resistance. So these are everything that drives the work we do. These are the core features. Here at Mary Greeley, we've had an antimicrobial stewardship team since 2013, back when it was formed with pharmacist Gary Bailey and Dr. Arbulu. They did a great job. That was before it was required. They really got our group up and running. And then after that, the CDC released the core elements that all hospitals needed to begin to adapt. That group, Arbulu and Bailey, won some in local infection quality awards. And as they rotated out of working here at Mary Greeley, Dr. Fulton and I ended up taking over the program, Dr. Fulton before me, and we really ramped up the pharmacist involvement with the transition. We got more pharmacists specially trained in antimicrobial stewardship to be more specialized and help support the program more broadly. We've added this to our pharmacy PGY1 residency program as a requirement. Every hospital in the nation needs pharmacists focused on this topic, at least partially, so we want to help teach and spread that knowledge. We like following the rules and doing the core elements, but we wanted to take it to the next level and apply for a Center of Excellence designation. So we ended up going for that. That just means that we're not just doing the bare minimum. We're looking to be innovative. We're trying to stay on top of all the guidelines and bring things to the patients and providers at Mary Greeley that is more advanced than just basic bare minimum information. So our program consists of the leadership We have admin support. We have Dr. Fulton and myself as co-chairs. We report to our pharmacy and therapeutics and infection prevention teams. Like I said, the pharmacists are heavily involved in the daily reviews of patients on antibiotics. Our infrastructure is that we schedule a meeting weekly with the ID provider to discuss cases, review data, and along with that daily work the pharmacist is doing. And then we have our own committee meetings and report to several quality committees the work that we're doing. Here's just the announcement. I guess I did want to mention we are the only Center of Excellence in Iowa for this award. So here's some others that got the designation along with us in the past. Here's a map of where centers of excellence in antimicrobial stewardship are located in the U.S. and internationally. So we're the dot in Iowa. And why is this important? Why do we want to be extra innovative here and on top of this information? The antimicrobial resistance threat is one of the big reasons, aside from patients not being harmed. The CDC puts out periodic data on threats that are serious and urgent on resistant pathogens. And through COVID, as you might expect, we had an increase in all, except for hospital onset MRSA. It remains stable, but there's increased resistance occurring. So we need to stay on top of that and not let our guard down. The next report the CDC will put out on those, that latest data is from 2022 that they had. They're expecting to put out updates in 2026. So we'll use that and look at that and see how that fits in with our program. Here at Mary Greeley, along with the CDC core elements, they require that we submit our antibiotic usage data. So that's a big metric of our program that we track. We do an adult antibiotic usage and pediatric antibiotic usage. And the yellow dotted line is the modeling from CDC predicts that that's at that line, that's how many antibiotics we'd be using if we met a SAR of 1. That's what they call it, the ratio of the predicted antibiotic use. We have been, in the past 5 fiscal years, below the SAR of 1. So what that means for us is that we're using less antibiotics than were predicted for us using the CDC modeling. It's not, perfect. It does adjust for an organization our size and patient population, but if anything, it just gives us a good, we feel like we're on the right track, not overusing. So it's just a metric we keep track of. And then we dig into antibiotic groups like narrow spectrum beta-lactams and broad spectrum antibiotics. And of note, I don't have this on the slide, we use more narrow spectrum beta-lactams here at Mary Greeley than broad spectrum. So we use less than predicted. So we're kind of okay with that. We feel like our antibiotic use overall is low. And if we're using more narrow spec, we're just maybe more appropriately using our antibiotics. We do look for any new trends here and there, but that's kind of our overall view on our modeling. With the metrics that we use for our antimicrobial stewardship, we track the daily work the pharmacists do to support the providers taking care of the patients by the intervention types that the pharmacists are making. So the pharmacists are looking at all the antibiotic patients, making sure that guideline concordant choice and duration are being used. And if not, they're just suggesting or helping remind the provider if they need it of what the options are moving forward. The pharmacists do IV to oral antibiotic changes. They do optimized dosing based on renal adjustments that need made, and they'll look at cultures for bug-drug mismatches. Overall, these can help, maybe get a patient de-escalated from IV therapy and potentially ready to go home on oral sooner, decreasing length of stay and less adverse events such as C. diff. We also track that. Overall, we know the pharmacists are making quality interventions that are useful to the providers by tracking that our interventions are being accepted. So between this last fiscal year, we had about 800 to 900 interventions made. And of the ones that were not just pharmacist driven, 85% of those were accepted. So that's well above our goal of 75% acceptance. So they have a great relationship with the providers on antimicrobial stewardship, and the providers are doing a good job of looking for those suggestions. The type of interventions, like I said, are dose optimization. Stop means, are they ready to stop the antibiotics now? If they notice certain features of the patient's improvement and they've met the guidelines for duration, it's just a little note they might put and see if that's accepted. Often there might be some complex issues going on with the patient where guidelines or literature states an ID consult would be best, so they can make recommendations like that. So here's just a list of all those types of interventions that are being made. Recently, Epic, I got access to track antimicrobial days per 1,000 days present, just kind of normalizing for patients' stay here at Mary Greeley. Here's the data. I mean, you can see over time our antimicrobial days are going down per 1,000 days present. So it's a really new metric that I've just gotten. So we'll just track that and, notice if it goes up. And we always include this slide. It's definitely nothing that we form the strategy of our program around, but it is anti-infective costs per patient day. We have data way back to fiscal year 14, and through the latest fiscal year, we've shown a decrease in anti-infective costs per patient day, and there are multiple reasons that can happen, and we wouldn't have this drive our interventions, but it's just a nice metric it's often asked about. Moving on from the pharmacist piece, I noted that we have a team. It's not just pharmacy and providers. We also have lab involvement, among others. So we always like to highlight our collaboration. Microbiology does so much, and it's difficult work. So we're really glad to try and understand and get help from them on the topic. With all the testing, the rapid testing available, the urinalysis criteria update that happened in the past few years, and just using their tools to get earlier diagnosis and rapid narrowing when possible. The lab helps, contribute to a great antibiogram here we have at Mary Greeley available to the providers. In Epic, and it's a really nice one. It's a rolling 12-month antibiogram. They do one for non-urine isolates and they do one for urine isolates. If you note on ours, off on the left-hand column, they have the number of isolates, so you can take that into consideration when you're looking at the susceptibility data on how relevant it might be. If there's less than 30, you may not be able to apply that to your patient. But this is a very nice tool to have, very, very useful in certain infections. I'll just buzz through that, and we'll talk about how this is recommended in UTI guidelines later. Some other work that the micro lab has done with our providers is just adding little narratives to culture results, just giving people extra insight, like, hey, this urinalysis isn't showing evidence of infection, but if the patient's clinical picture, so it's not going to reflex the culture, but if the patient's clinical picture to you is still that they're symptomatic and need a culture, go ahead. It just kind of gives that extra explanation rather than just having cultures reflexing for no better outcome to the patient. I'll also talk about that initiative that they did in a little more depth here. Here's another example. When you get a sputum culture result and it's kind of here's many gram-positive cocci in pairs, and it's like, well, could that be MRSA still? You're wondering. So they added, because they know they don't find MRSA or staph, that there's no significant staph, MRSA, or Pseudomonas isolated. So it just gives that provider an extra confidence that they're looking at the culture accurately, and if they tried to cover for that, it may no longer be relevant. Another piece that's pretty complicated is interpreting the sensitivities of the culture results. Breakpoints are kind of hard to interpret. If you got a culture back saying it's sensitive or resistant to Penicillin tazobactam, you should just say sensitive or resistant, and sometimes it'll say intermediate. But they added in based on the latest guidelines out there, a sensitive dose-dependent Penicillin tazobactam. So if a provider were to see that, they might see like, hey, it is sensitive tazo, but I need to use greater dosing than I usually do. And that's where the antimicrobial stewardship team, they can really come in and help interpret that and give providers a reminder that's how that works, or you might need a dose increase based on the culture results. So things like that are occurring. So we can not just rule out an antibiotic that we used to, but know how to dose it appropriately. So that was a lot of the micro lab and just kind of the backbone of how our program works and stuff that we are working on. Now I'm going to jump into the most recent community-acquired pneumonia guideline update. I'll just note that usually the guidelines have been an ATS-IDSA joint venture. They did a 2007 and a 2019 guideline together. And while the IDSA physicians were very involved in this ATS guideline, IDSA did not end up endorsing these guidelines. So we can expect IDSA might also come out with a future guideline. And I can kind of get into what I've read about why they didn't endorse. But this guideline's addressing 4 central questions, 2 of which I'll try and address from the antimicrobial stewardship viewpoint. Should adults with community-acquired pneumonia who test positive for a respiratory virus be treated with empiric antibacterial therapy? And should adults with community-acquired pneumonia who reach clinical stability be treated with less than 5 days of antibiotics? First of all, the populations addressed in this guideline were patients presenting in the outpatient, inpatient, and then severe community-acquired pneumonia patients. Of note, COVID patients are not, these guidelines don't apply to COVID patients. Just very recently, COVID guidelines were updated, so you'll go to the COVID guidelines to treat those patients. Not included were immunocompromised patients, which are a lot of who you providers see, and then pediatric patients, of course. And a reminder for severe CAP, here's the criteria. You can have a major criteria or 3 minor. This is found in the order set here at Mary Greeley for pneumonia, the criteria for severe pneumonia. So jumping right in for outpatient, which isn't really things our program covers, but I'll put it in here to be a little more complete. Adult outpatients without comorbidities who have clinical and imaging evidence of CAP and who do test positive for a respiratory virus, the guidelines suggest not prescribing empiric antibiotics due to concern for a bacterial viral co-infection. That's pretty unanimous. The committee was 14 out of 15 voted in favor of that suggestion. For adult outpatients, however, who have comorbidities and evidence of CAP and test positive for respiratory virus, they suggest prescribing empiric antibiotics. This is where IDSA felt uncomfortable endorsing the guidelines. they were not comfortable with the evidence used to suggest prescribing empiric antibiotics and felt overuse may come from this. So we'll see how they evolve in what they recommend in the future. And just so you know, a suggestion from this guideline means there wasn't a whole lot of evidence. It's when they say we recommend that there actually was stronger evidence, and most clinicians would apply that guideline to their patient. But when we hear comorbidities, I always, when we had COVID and everything, you're like, they have greater risk, the patients with comorbidities. So there's not an exact science to which comorbidities would warrant that antibiotic treatment, but the members of the committee kind of put in which things they would agree to prescribe antibiotics in, and which conditions they had less agreement on. So when you talk diabetes, you're always like, is that a comorbidity we should be treating, or if it's really controlled, maybe I shouldn't. But so this is just here just as a information, and the providers will have to decide based on their patient and their perceived risk for a bacterial co-infection and the harm from missing that on their own, or apply the guidelines as they state suggesting. Moving on to inpatient recommendations. So for adult inpatients with clinical and imaging evidence of non-severe CAP who test positive for a respiratory virus, again, they suggest prescribing antibiotics for a concern of bacterial viral co-infection. Again, here's the other controversial piece, just like the comorbidity patients. And for inpatients with severe CAP who test positive for respiratory, it's unanimous. Everyone agrees those patients are going to be risky for a co-infection, and all voted in favor of, and it's we recommend, there's data to support co-prescribing or adding on antibiotics. The next topic in the community-acquired pneumonia guidelines is talking about duration. We're always wondering, how long do you need to treat? How early can you stop? It's not super clear still. You have to consider, as the clinician, the organisms that might require longer duration, like Staph aureus, Pseudomonas, Legionella, complications of the pneumonia, things like that. And as a note, who wasn't included in this duration concept, so I'll move on and see what they said about the durations. For an outpatient, and again, these guidelines are for immunocompetent adults who reach clinical stability, they suggest less than 5 days of antibiotics, but a minimum of 3 days. And it's a suggest, but most of the committee was in favor. Coming to inpatient, the immunocompetent adults with non-severe CAP who reach clinical stability, they suggest less than 5 days of antibiotics, minimum of 3 days. Here's a little, 11 out of 16 committee members voted in favor of less than 5 days. And then for immunocompetent adult inpatients with severe CAP who reach clinical stability, they need at least 5 or more days of antibiotics. And that was a strong recommendation, even though they noted there was low quality evidence. It's just a risk that if these patients don't get that longer duration, the risks to them are greater than what we know in the data. So they all almost unanimously voted in favor of 5 days or greater in severe community-acquired pneumonia. And then the final piece that is of interest to us here for treating patients with community-acquired pneumonia is the difference in the corticosteroid recommendation from the 2019 guidelines. Here they're saying for adult inpatients with non-severe CAP, we recommend not administering systemic corticosteroids. That was unanimous. There's a lot of evidence. The harm from that outweighs the benefits. And for adult inpatients with severe CAP, here's where it gets different. It does recommend that systemic corticosteroids are used. So I think maybe this, if a septic patient had pneumonia, this is already a recommendation, but this is just making it a little more clear to use those. Something like hydrocortisone, 50 milligrams, IV every 6 hours for a severely ill CAP patient. So just to recap, the IDSA is publishing, I think it's a statement. I actually may need to back up on my guidelines soon. But they're going to publish something of their own soon. And then, should adults with community-acquired pneumonia who test positive for a respiratory virus be treated with empiric antibiotics? We kind of answered those with comorbidities should per these guidelines. It's a little controversial to leading to overuse, so jury's still out maybe. And then some patients can be treated with less than 5 days of antibiotics, but those with the severe should definitely get 5 or more days. And then add corticosteroids in severe CAP. Okay, switching gears to UTI. Here's where I kind of wanted to start with a little Mary Greeley process improvement and then lead into the UTI guidelines. 45 to 83% of patients in general receive inappropriate antimicrobial treatment, often due to an emphasis on a lab result rather than the patient's actual symptoms. Here's just one of many articles on the topic highlighting that in a study, treating asymptomatic bacteria. This is where our lab's awesome at being thoughtful here. They increased the threshold for which the urine, you can correct me too if I'm not saying it right, the threshold for which a urine culture would reflex after a urinalysis from greater than 5 white blood cells to having at least 11 to 20. Prior to that change, the growth on the cultures that were then resulting were not as much significant growth. There's a lot of like cultures that were no growth or 3 or more colonies. When they had made that small adjustment, which is very much in line with how others in the literature state is appropriate, the cultures that then resulted were much more significant growth, more actionable type cultures, not a lot of this like no growth. So it was just more effective use of the culture than it was prior to the adjustment, and more in line with how to appropriately use cultures. So that was great. And then the complicated urinary tract infections, the clinical guidelines for treatment and management were updated by IDSA in 2025. This is important because lifetime UTI risks for women are 53%, and for men, they're 14%. So that's still a decent amount of risk. The interesting piece that was updated in this guideline was, I say definitions, but I believe they call it classifications of an uncomplicated versus a complicated UTI. And these clarifications came about just to help guide treatment, not change how you diagnose UTIs in general, but which made it allowable for men to fall into an uncomplicated category, which we'll see here. And then we'll talk about antibiotic selection, IV to PO, and duration again. So the new classifications, this is straight from the guidelines, took the old uncomplicated UTI that could only be applied to women, non-pregnant, and then a pyelonephritis was its own separate, and then complicated UTI was just everything else. It was reclassified to uncomplicated UTI. It's talking more about the location. It's just a UTI confined to the bladder in afebrile women or men. Once you extend beyond the bladder, it becomes complicated. and those with catheters, indwelling catheters, would be considered complicated. So uncomplicated UTI classifications for the guideline purposes. Again, here's straight from the guidelines, kind of how the patients present. It's talking about their local bladder signs and symptoms, and that they wouldn't have any of these other systemic signs and symptoms. It's not generally going to be those patients with catheter stents, nephrostomy tubes, things like that. So uncomplicated is pretty, just add men in as an option now, which I think a lot of providers already did that a little. This isn't part of the guideline, but just for completeness, here's the usual uncomplicated UTI treatment that can be used. And now for men, it would be guideline recommended. For the complicated UTI classifications, again, this has all the systemic symptoms in the hardware in the bladder area and kidneys, and it has a nice little diagram on how to approach these. So these guidelines really wanted to emphasize a 4-step approach on how to choose your empiric antimicrobial therapy for complicated UTIs. So they really want us to be thinking about the severity of the illness first, and then go down the algorithm. Because if they just told you which antibiotics to use, maybe in New York City that antibiotic makes sense, but here it wouldn't be our best choice. So they didn't want to start just naming the antibiotics. They wanted us to think of severity first, and then consider risk factors for the patient to have resistant organisms, and then patient-specific factors. And only if you're septic or septic shock should you then start looking at your antibiogram. So for a complicated UTI, the antibiotic choices, once you know it's complicated, and if they are septic shock or sepsis, you're going to use the 3rd or 4th generation cephalosporins. Again, there's no preference to which one you're going to choose. You're going to look at your patient and what are their prior cultures, what are their risk factors for multiple drug-resistant organisms, and then you can decide which antibiotic to use. And then lastly, you can look at your antibiogram and decide whatever target I'm going for. There needs to be at least 90% sensitivity if they're septic shock and 80% sensitivity if they're septic. If you have no clue what, there's no past history to lead you to a different organism, then E. coli is the default target. Complicated UTI, the guidelines talk that once a patient's becoming clinically stable, you can switch them from IV to oral. There's great, as long as there are antibiotics available that match their bacteria, and you go ahead as they're stable to transition them to oral, and then for the duration that is recommended, make sure the source is controlled. And then here at Mary Greeley, the pharmacist, we have this criteria kind of built in to for those really obvious antibiotics that have good oral bioavailability, to just be switched by the pharmacist without waiting around for the physician to have to round and see a note. So we do that here. And then the duration for most patients, it is, again, we're talking complicated, is 7 days. If they use the fluoroquinolone, Cipro, or levofloxacin, it could be 5 to 7 days. And then others that might need longer durations, not improving yet, severe sepsis, immunocompromised, just any other obstructions, abscess, they'll go 10 to 14 days. I have this in here again. I don't know. So the key takeaways are there's new classifications for uncomplicated and complicated UTI. Kind of use that 4-step approach. Think severity first when you are choosing your empiric antibiotics. Don't go straight to that antibiogram. And then the durations can be, for complicated, 5 to 7 if for a fluoroquinolone, 7 if not, and then you can go up to 14 if you need to, or until the patient's recovered. And then IV to PO is always a great idea when they're ready for it. So that's UTIs in the update. The final topic here is something our program's been in tune to, and it's penicillin allergies. It's important. 10% of the general population report a penicillin allergy. Actual incidence of anaphylaxis is very low. 80% of patients with an actual immediate IgE-mediated penicillin allergy lose that sensitivity after 10 years. So that allergy wanes over time. And then, but it is the one we most commonly see in the medical records. And reactions are typically listed like hives, a rash, and then just unknown reactions, nothing even entered sometimes. So as a reminder, there's the type 1 IgE-mediated immediate allergy, which includes the anaphylaxis. We have the type 2 through 4 allergic reactions, and these are all delayed. So when we start talking about the penicillin allergy and how we're going to risk stratify a patient to see if they can still get a penicillin antibiotic or another beta-lactam, this is where this will matter to us. And it's hard to know, like we just said, when we look at the chart and see nothing for a reaction or just rash. And I guess I do want to note the most common reaction is a delayed just maculopapular rash. And the literature says patients, when re-exposed, only 10% would even have that same rash again. So just, again, it's problematic for prescribing antibiotics. And it's problematic because beta-lactam antibiotics, which penicillin is a beta-lactam, is the preferred agent for many common bacterial organisms. So the penicillin allergy label affects antibiotic choice, and it can lead us to use suboptimal antibiotics, which can lead to suboptimal outcomes. There's plenty of studies out there discussing these findings. They're not just in theory, they're actually found, and I have that on the next slide. It leads to alternative antibiotic choices for surgical prophylaxis, which can then in turn lead to more surgical site infections. And then use of non-beta-lactam agents in general can have increased risk for C. diff infections, MRSA, or even VRE. Here's just like a little sample of studies out there where it showed that truly the penicillin allergy led patients to get a non-penicillin antibiotic and worse outcomes than their counterparts who weren't labeled with the penicillin allergy. The second one is a surgical site infection study that did show that patients received non-beta-lactam agents had greater surgical site infections in 90 days. And then those alternative antibiotics are often, like we said earlier, associated with more C. diff infection risk, and possibly MRSA. Vancomycin is often a choice when you have a penicillin allergy. So those are just actual studies showing that. Here at Mary Greeley, it isn't uncommon to see an order set that kind of looks like this, and so we have room to improve. It's antibiotic prophylaxis before a surgical procedure. It has your cefazolin, which is the preferred antibiotic, and then if patient allergic to penicillin/cephalosporins, clindamycin. So that there's not a lot of judgment. You know, if you're a nurse assisting a provider and you just see penicillin allergy, you might just be apt to pick clindamycin based on the order set direction. So we can work on that. But what are you going to do once you see that penicillin allergy and you have a surgical procedure coming up? To do it justice, you would need to if you have the patient there, do include interview questions to get at what type of reaction they actually had. Really get that allergy classified and determine, was it an IG-mediated reaction? Because we have more options once we kind of know what type of reaction we're dealing with on what the patient's actual options are for antibiotics. If you don't have the patient available, just doing a thorough chart review to find out the type of reaction they might have had in other antibiotics they may have already received with no reaction is a very important part. Here, we use EPIC. This is a snapshot of someone else's EPIC, but as a reminder, if you were to do a deep dive into the chart to try and determine what other antibiotics the patient had, you can go to the meds tab and filter by therapeutic class and pick antibiotics and find that information much more quickly. Once you've looked into your patient and you've determined what type of reaction they had to which antibiotic, you can kind of do a risk stratify. This is just an example of a decision tree. We don't have one in play for certain at Mary Greeley. Lots of places have their own version. So once you risk stratify, you can put them into a mild, moderate, or severe risk, and that kind of gives the provider their options. If they're the mild risk, they can do a direct challenge with just the actual agent, or if they are concerned, they could do a little graded challenge. All the way up to the PST means penicillin skin testing, which really isn't an option that's really available like in the hospital. So some clinics will have that option, and maybe the patient would need referred for that. But if they're moderate risk, you could also do a graded challenge. So our ID providers, I know, already know this information and do this risk stratification. So if you had a patient that you needed this advice on, they're familiar with how to do this. And then desensitization. If a patient has anaphylaxis and an antibiotic is needed to be given, then you might get allergy and ID involved. And if you truly were able to delabel just from a chart review, just do your best to get that drug updated in their allergy profile. Those are very hard to even if they get removed, it seems like they find their way back. So this is difficult, but do your best to get that removed from the chart. I know I report that I don't have an allergy anymore, and it's always still there. And newly at Mary Greeley, if a patient does report a penicillin allergy, on discharge instructions, we just give them a little more information on what does that mean to them and what should they do with that information. A lot of this risk stratification talk, it came from the Drug Allergy 2022 Practice Parameter Update, and there's just numerous ongoing studies, and they urge that antibiotic stewardship teams work with everyone to create some sort of risk stratification at your organization. But when you're trying out, when a patient reports a penicillin allergy, it's not the beta-lactam ring that is causing the problem for cross-reactivity to other penicillins or cephalosporins. It's the side chains, the R1 side chain. So actual cross-reactivity isn't just blanket statement to all beta-lactams. So we can have even more, after we get that risk stratification, we can have even more information that we can use to help pick an appropriate antibiotic. I think I'm kind of running out of time. In general, cefazolin, our workhorse for surgical perioperative prophylaxis, doesn't share a side chain with any beta-lactams. So if a patient reported penicillin allergy anaphylaxis, cefazolin is safe to use. That 2022 update had this type of information, but one of our pharmacists created it. We adapted it from other organization and created it for us to use here. This is a nice chart where it helps you understand cross-reactivity from one beta-lactam to another. So here we're highlighting cefazolin has no X or triangle, so it's good to go with all of these other beta-lactams, and that's kind of what we're showing here. And then if you had ampicillin and cephalexin, if the patient reported an ampicillin allergy and then you came to the chart and wanted to prescribe cephalexin, you'd see there's an X. A cross reaction is much more likely and you should avoid those. So you wouldn't want to try that one when you're doing that graded challenge necessarily. You'd want to use different antibiotics using a chart like this and what their actual reaction was. So we're kind of testing this out as we get random questions in the pharmacy to help providers when they do question a patient's penicillin allergy and their antibiotic options. I love this chart. And this whole topic is very timely. Next week is U.S. Antibiotic Awareness Week. It's just a time to bring notice to this topic. It's very impactful that we stay on top of this and not just lose sight of it. So that's what our team's here to do, keep track of that for us all. And that concludes a few updates on a few topics. Any questions? Yes.
Jill, thanks for your presentation. I have a couple of questions. First one is, do you track how many patients come in with C. difficile infections and how many of them can you trace to the antibiotics they used?
Yeah, actually, I'll give credit to our team members on the infection prevention team, the nurse, Cheryl. She does track that. She keeps close track of that hospital onset. And when she gets a case, we do look and see what antibiotics were on board and if they're associated. And we haven't noticed a correlation in, other than just antibiotics in general, we haven't noticed any correlation in risky antibiotic use in those cases.
And this program is mostly for inpatients, but what are the opportunities to maybe work with McFarland Clinic on outpatient antibiotic stewardship?
Yeah, I should have looked into that ahead of time. So CDC has core elements for outpatient. So it's a whole separate set of metrics. And I did think McFarland is doing some work there, but I actually just don't know. So antibiotics at discharge from Mary Greeley, things like that, is a spot we could still look into and try and impact here and collaborate on that. Yeah.
So I was just curious, immunodeficient, is there a more specific definition of what that means?
I think it's just kind of like the comorbidities thing on who I haven't seen that they listed out all the immunocompromised conditions explicitly, like is a diabetic immunocompromised, is a
it's not just measuring their number of white cells or something like that.
No, I don't, not as far as like the type of patients that fit the guideline.
Just curious.
And what are the chances that there could be some other medication stewardship programs? Because there are obviously a lot of other medications that are more or less effective and obviously more or less expensive. So is that still a possibility in the future for pharmacists?
Yeah, I think in general, we're just generally stewards of trying to use the medications here at Mary Greeley for the right reasons, for the right patients. So not as robustly as the formal program we have that, but like opioids too have an opportunity for stewardship in totally different ways than antibiotics. So stewardship on just giving patients the right drug at the right time and dose and everything is always a useful thing for us to look into. Thank you.
It's a wrap.